Okay, in this scenario, I'll show you what happens if you're met with a baby who's got really bad lungs, very stiff lungs, and perhaps our standard ventilator settings prove not to be quite sufficient to achieve the tidal volumes that we need, and how we recognise that and how to react to it. So let's say I've been asked to see a baby who is 1.5 kilograms in weight. The nurses have been looking after overnight, and they've found that they've had to turn up the FiO2 in order to get the baby to saturate. This baby's been ventilated for some time. They've turned up the ventilation FiO2 to 60%. The baby had been ventilated with a tidal volume of 4 mils per kilogram and seemed to be stable in that earlier in the night. So 4 mils per kilogram, 4 times 1.5 is 6 mils. So let's go and have a look at what was set. So FiO2 60% has been dialed up overnight. 4 mils per kilogram, that is 6 in absolute terms. 6 mils is the tidal volume. And the I time set was 0.35. The respiratory rate that had been set previously was 60. PEEP of 5 and Pmax of 25. So those were what was set. And what did we get? Well, yeah, we did get a tidal volume of 6 mils, but interestingly, notice that the peak inspiratory pressure required and measured to deliver that tidal volume of 6 that has been recorded is 23. So that's quite high and quite near that Pmax. But let's say we're faced with a bad gas. CO2 is a moderately bad gas, say CO2 is 8, and the baby's a bit acidotic with a pH of 7.18. Well, the first reaction to that is typically to increase the tidal volume. So we're on 4 mils per kilogram. Let's go to 5 mils per kilogram. It's a 1.5 kilogram baby, so 5 times 1.5 gets you to 7.5. So I'll dial in 7.5 in our tidal volume. That's it, 7.5. So I'm hoping, right, 7.5 mils per kilogram, that should do the job with this. But bear in mind, this is a baby with very, very stiff lungs I'm describing, and these are the challenges that we might get. So I've dialed in 5 mils per kilogram, which works out as 7.5 mils. Well, lo and behold, our tidal volume that we're achieving is only 6.6, so we're not able to get there. And what has happened to our delivered pressure? Well, it's 25. So that is the same as our Pmax. So the ventilator isn't able to get to that tidal volume that we would like, because our Pmax is at 25. So this is not an uncommon situation. And people are wondering, well, we're not achieving our tidal volume and we've set it there. Why is that? So you look at the delivered peak inspiratory pressure. So if you've delivered that peak inspiratory pressure to Pmax and you're not getting there, then under these circumstances, you may have to go to a Pmax of up to 30. So I'm going to do that in this situation because that is exactly what you might be faced with doing. Providing you're ensured that your ET tube's in the right place, that's not in the right main bronchus, you've done an X-ray and you've taken care of the basics. So I have turned the Pmax up. So our default might typically be 25, but sometimes you have to go to a Pmax of 30. So I've turned my Pmax up to 30, hoping that I'm going to achieve the tidal volume of 5 mils per kilogram to get a better CO2. So that's the set tidal volume as before. Well, what are we getting? Yes, we are getting now that tidal volume 7.5. And my finger goes here to point to the peak inspiratory pressure that is being recorded. This is actually required to deliver that tidal volume, and it is right up there at 28. So this is an example of a baby with really, really stiff lungs. So that's the kind of scenario you might be faced with. Now, before we close, I'm just going to just pause for a second. I just want to go through one little caveat, really, for all babies, you know, and I'll just hold this up actually in front of the camera. Caveat for all babies: you have to get the basics right, and that includes getting your diagnosis and getting an X-ray appropriately so you know what you're dealing with. Make sure you have the correct size of ET tube, that's above the carina, without a significant leak. Remember that volume guarantee is not effective oftentimes if you've got a big leak over 50%. And you can also get a big leak, of course, if you get a chest drain and a pneumothorax. That accounts for a big leak. Don't ventilate with volume guarantee a single lung. So if you've got your right main bronchus intubated, you don't really want to be giving those babies 6 mL per kilogram down one lung. Consider sedation, muscle relaxants, surfactant, antibiotics, fluid boluses, inotropes. Get all the basics right for sick babies such as this as you're fiddling with ventilators. Everybody needs to remember that in ACPC mode, all patient breaths, if they're above a certain trigger threshold, will be supported. So a set rate is only a backup rate, and so reducing the rate is not very effective usually ineffective as a weaning tool. And that's in contrast to SIMV. In SIMV, the set rate is the backup rate also, but when babies breathe above that rate, unlike in ACPC, in SIMV the ventilator won't support every breath in SIMV. So in SIMV that can make weaning a rate feasible and simpler when we're weaning babies if we move to SIMV with VG on. And it's a general rule of thumb that we should be considering extubation if if a backup rate is less than 30 breaths per minute, and if babies are less than 30% of oxygen. That's a rule of thumb, but of course we have to be very careful with decisions around planned extubation. And in conventional ventilation, if we're needing peak inspiratory pressures of above 25 or 28 centimeters of water, we need to be having x-rays done and to be considering high frequency oscillation. So these caveats are really, really important for all babies.